We are having the dangerously wrong conversation about Ozempic and our GLP-1 medication. While the internet argues about cheating, willpower, and Ozempic phase, a quiet biological revolution is happening inside the body that almost nobody is tracking. Today, I'm not going to talk about dress sizes, goal weights, or before and after photos. Because if you only focus on these numbers on the scale, you are missing the point of these drugs entirely. I'm going to show you the hidden cost GLP-1 medication charge to your muscles, your brain, your hormones, and your gut. I'm going to explain why losing weight on these drugs can feel like taking off a heavy backpack for some people, but for others, particularly women in midlife, it can feel more like slowly removing the support beams from a bridge. And later in this video, I'm going to ask you to stand up and take a simple 30-second test, the sit to stand test. It predicts your functional reserve and your long-term resilience better than almost any blood test your doctor will run. And you must know your score before you take your first dose. If you are new here, welcome. I'm Dr. Elena Chirikhina, lifestyle medicine advocate. On this channel, we talk about health as biology, not trends. If you care about science-based, honest discussions about your body, please subscribe. This channel is about understanding your physiology, not fighting it. Let's begin with something uncomfortable, but necessary. If obesity were simply about eating less and moving more, none of us will be here right now. We will not see obesity rates rising across every single continent, every income level, and every generation, all within a few decades. Human biology has not changed that fast, but our environment has. Obesity is best understood as systems disease, a fundamental mismatch between ancient biology and a modern world. Think about it. Our physiology evolved to do three things very well. First is seeking energy. Second, store energy efficiently. And third, last one, to defend body weight fiercely during times of scarcity. For 99% of human history, these were survival superpowers. But today, we live in an environment of constant food availability. We are surrounded by ultra-processed foods engineered specifically to override our society's signals. We live with chronic stress, sleep disruption, and a sedentary default. Add to this your genetics, your epigenetics, and even your childhood programming. By the time an adult walks into a clinic, their biology has been shaped for decades by this environment. And suddenly, obesity stops looking like a moral failure and starts look like biology doing exactly what it evolved to do, just in the wrong context. This is especially clear when we look at children. Before the age of 5, obesity risk is heavily shaped by parental metabolic health, feeding patterns, sleep rhythms, and the stress environment of the home. Children do not choose their food environment, they inherit it. After early childhood, obesity becomes increasingly driven by lifestyle patterns, social norms, food availability, sleep deprivation, and stress physiology. This matters because GLP-1 medications do not enter a neutral system. They enter a system already shaped by decades of biology and environment. And if we don't understand that system, we risk solving one problem, weight, while quietly creating others. This brings us to measurement, because one of the biggest mistakes in modern health is measuring the wrong thing and then acting confidently on it. We rely on body mass index. But BMI measures mass relative to height and is blind. It does not tell us how much of that mass is fat. It does not tell us where that fat is stored. It does not tell us how much muscle exists. And it tells us nothing about how well the body functions. Two people can have the same BMI and completely different health risk. One might be metabolically healthy with half muscle mass. The other might have normal weight obesity with dangerous visceral fat. That's why medicine focuses on waist-based measures. The waist to height ratio. This answers a simple question. How much fat is stored around the organs relative to the body frame? Visceral fat is fat around the organs, is metabolically dangerous. It drives insulin resistance, inflammation, hormonal disruption, and cardiovascular risk. A simple rule works surprisingly well. Your waist should be less than half of your height. This ratio predicts metabolic risk better than BMI across sexes, ages, and ethnicities. Another measure is the waist to hip ratio. This answers a different question. Where is fat stored, centrally or peripherally? Hip fat is often metabolically protective. Abdominal fat is not. This ratio is especially important in women with polycystic ovary syndrome and in midlife transition, where fat redistribution is common. Why ethnicity matters? Most medical cut-offs were developed using predominantly white male population over the last 70 years. This means South Asian populations develop diabetes at a lower BMI, East Asians accumulate visceral fat earlier, Hispanic populations might have higher liver fat risk. African ancestry populations often have higher muscle mass at the same BMI. These are not cultural differences, they are biological distribution patterns, which is why trend-based and functional measures often outperform static thresholds. So if BMI is failing us, we need a better tool. But even the best measurements fail if we don't understand the chemical signal changing the system. This brings us to biggest misconception about GLP-1. It's not a fat-burning hormone, it's a signaling hormone. It's produced in the gut in response to food and communicates with the brain, pancreas, and your digestive system. GLP-1 medications amplify this signal. They reduce hunger, they increase satiety, they slow down gastric emptying, they alter reward signaling, they reduce food noise. For many people, this feels like relief. For the first time in years, the constant mental chatter about food quiets. But appetite suppression is not neutral. Appetite is not just hunger. It's connected to pleasure, reward, motivation, and your identity. When appetite drops, intake drops. When intake drops, recovery capacity drops. This is where muscle, hormones, and gut health enter. Muscle, the most ignored risk. Weight loss without muscle protection is not health, it's shrinkage. Muscle is not a static tissue, it's metabolic tissue. It clears glucose from the blood. It stabilizes joints, it supports hormone, it protects aging resilience. When people lose weight rapidly from dieting, from the surgery or medication, they lose fat, water, glycogen, and muscle. Across GLP-1 studies, roughly 25 to 40% of their weight loss is lean mass, Men often lose more muscle in absolute kilograms. Women lose less muscle in kilograms, but lose a larger percentage of their functional reserve. That difference matters. Women start with less muscles, so they reach functional vulnerability sooner. This is why we use a functional test, not just scans. The sit-to-stand test measures whether your leg and hip muscles can repeatedly move your body against gravity. This is medicine versions of squat. It predicts independence, frailty risk, and tolerance to weight loss. A good score tells us you have muscle reserve. A declining score is an early warning, often before muscle loss shows on scans. This is why sit-to-stand should be measured before GLP-1 use, not after damage is done. Performance is age-related. In middle age, if you cannot perform 20 sit-to-stands under 30 seconds, you are already entering a zone of functional risk. If you start medication in this state, your priority must be building strength, not just losing weight. GLP-1 is not hormone neutral. In men with obesity, weight loss through GLP-1 often leads to improved testosterone levels. This is because excess visceral fat converts testosterone into estrogen. When the fat goes, testosterone rebounds. This creates a protective safety net for muscle in men. For women, this story is more complex. GLP-1 does not restore estrogen. In premenopausal women, improved insulin sensitivity might improve cycles, especially in PCOS. But in perimenopausal and menopausal women, estrogen is low or fluctuating. Estrogen is anabolic. It helps maintain bone and muscle. When you combine low estrogen and low calorie intake from GLP-1 medication, you create a catabolic storm. This creates a perfect storm for muscle loss and bone density reduction, if not actively protected. This is why women lose weight efficiently on GLP-1 and why they need more careful monitoring, not less. Women on these medications need to be aggressive about resistance training and protein intake to counteract this hormonal vulnerability. GLP-1 medications work through the gut, and the gut responds. Slower gastric emptying can cause nausea, reflux, constipation. Gut motility matters. When food sits in the stomach for too long, it ferments, causing bloating and discomfort. This is why walking after meals is one of the most powerful underused tools. It improves glucose handling, it stimulates motility mechanically, it reduces discomfort. Fiber intake matters, but timing and dose matter. A low fiber gut struggles more on GLP-1 medication, but jumping into high fiber overnight can worsen symptoms. We often see patients trying to eat clean by consuming massive raw salad on day one of Ozempic. This is a recipe for disaster. Raw vegetables are harder to digest. When your digestion is slowed by the drug, that salad sits there. Start with cooked vegetables first. Soups, stews. Prepare the gut before medication, not repair after. GLP-1 is powerful medication, and power requires judgment. These medications are good for people with obesity and metabolic disease, people with failed lifestyle-only approach, people under medical supervision. But extra caution needed for people with eating disorders, severe GI motility disorders, unmanaged mental health conditions, pregnancy or fertility planning. They should never replace sleep, movement, protein, resistance training, and mental health support. Medication can open the door. Lifestyle determines what stays inside. The non-negotiables: sleep regularity. Sleep is when your body repairs the muscle you broke down during exercise. Without it, the drug won't work as well. Morning light sets your circadian rhythm, regulating hunger hormones naturally. Protein at every meal. Aim for 30 grams per meal minimum. This is the signal to your body to keep muscle. Fiber gradually increased. Start slow. Prioritize cooked sources. Resistance training 2-3 times weekly. This is non-negotiable. You must lift heavy things. Walking daily for gut motility and mental health. Alcohol avoidance. Alcohol is empty calories and ruins sleep quality. Pleasure replacement. GLP-1 reduces food pleasure. You must replace it with life pleasure, movement, creativity, connection. Otherwise, weight loss becomes joy loss. You might find yourself feeling flat or anhedonic. You have to shadow joy, just like you shadow your workouts. GLP-1 medication is not the enemy, and it's not the savior either. It's a tool, a powerful one. But tools require understanding. Health is not a number on a scale. It's the ability to move, recover, think clearly, and age with strength. If you want science that respects complexity, biology, and long-term health, follow this channel. I'm Dr. Elena Chirikhina, a lifestyle medicine advocate. And here we don't chase trends, we understand systems. Subscribe, and we will continue this conversation.